Hi, and welcome to episode 174 of the Untethered podcast. Today we have Dr. Amy Luedemann joining us. Amy is a board-certified biohacking, laser, airway-focused, innovative pediatric dentist. She loves children, finding minimally invasive solutions to root cause problems, and she believes each and every individual has everything they need inside of themselves already to be their very best selves. So her role as a healthcare provider is to remove obstacles and enrich the environment to allow all of her patients to take off and thrive. Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and or medical treatment of a qualified healthcare provider. Welcome to the Untethered podcast. I am your host, Hallie Balkin. I'm a certified orofacial myologist, feeding specialist, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, tethered oral tissue, and airway space. I challenge you to keep an open mind and join my mission to get this information out to the masses. Let's get started. Well, Amy, I was actually sitting in my bed last night, like thinking about our conversation we were going to have today. I was like so excited after the initial phone conversation we had. And I know all the listeners are going to just eat this episode up. So welcome to the podcast and thank you for joining me.
Thank you so much for inviting me. I'm really excited. And my associate, I was talking to you yesterday and she's like, oh, you're going on that podcast? I totally listen to that podcast every week. That's so exciting. And so just thank you so much for inviting me. I'm excited too. This is going to be fun.
It is. We're going to have fun. And we have very similar interests in like the early intervention, birth to 3, age group. And so I'd love for you to share how you got into working with that birth to 3 age group and just, what is it you're doing in your space with that age group as well?
Yeah. Well, so of course I'm a pediatric dentist, so that kind of lends itself to the kiddos, but even as a pediatric dentist, we don't, we're not even trained to start at birth for sure in residency. So that's a lot of afterwards, but, gosh, I think the way I kind of got into the world of really treating babies was through Mark Moeller and his group and going to Joy's class and then laser courses and so forth. But Jessica Altamira helped me to set up, I think, the 3rd interdisciplinary clinic in the United States. So we have an osteopath, or I have also a chiropractor who does cranial osteopathy, as well as 3 IBCLCs. And so we brought that group together. It was originally Rosalba and myself and our osteopath, Elena Williams. And that was just wonderful. That's kind of where we started with having this approach. We ask the patients to get ready outside the practice, but I wanted someone there to verify because I'm not a body worker and, not all are equal. So sometimes there were red flags. We found, broken clavicles and one kid we actually sent away to get work on and they had a cancer diagnosis. Like we're very observant and looking at the whole baby. And that's been such a huge learning experience. And then I would say probably some years into doing that, I started noticing I like to see the kids every 3 months for the first 3 years of life if they live close enough. And what I was doing during that time was seeing, did we heal nicely? Are we meeting our milestones? And also looking at the jaws. And I noticed that for most babies that were born with tongue tie and who had a high palate at 1 and 2 and 3, they were still having a high palate. And this stressed me out because what I had learned in all my CE is like, fix the tongue, breastfeed, try some baby-led weaning, and it's going to be all great. And it's really not all great for a lot of kids. They still don't have the structural changes for lots of reasons. So that kind of just, got under my skin. Like, what can I do different? What can I do different? Then I learned from Derek Nordstrom, because I'm an ALF provider. So I learned about a neonatal ALF. And so I tried that a little bit, but I think the pandemic kind of happened sometime shortly after starting that. So I stopped doing that a bit. Well, then fast forward maybe a year ago, and we had a little kid come to our practice that was almost 2 and was being referred for tongue tie. And we sent them for the team approach to a really awesome SLP at low tone, all these other issues. dad found him in his crib 2 weeks later, and it was just heartbreaking. And I thought, I cannot like sit around and just watch these kids until they're at an age where I have appliances that I know work. So that got me started with my people, my clan, and we have been innovating. And so now we're working on, and because it is a little bit of a labor of love and kind of a lot of work, but we're seeing tremendous results. And I'm doing now 0 to 3-year-old, trying to widen their palate with an osteopathic complementary appliance through a team approach. And that's been super exciting. And also doing the laughter laser assisted functional therapeutic release and baby lace is also what it's called. It's the same procedure. So that's been another game changer, helping us to see sometimes differentially what's a tie or not a tie. So that's kind of where my heart is right now, in developing better things, because there's not a lot of options for them if they have airway issues or sleep issues at this time.
Oh my gosh, we said so many things and I was just like sitting here like, yes, yes, yes. Oh my gosh. We've had a provider on the podcast in the past who's used baby lace and talked a little bit about it. Like very briefly, it wasn't really the focus of the episode. So there's that, and then SIDS and like just some different things that came up. And I'm like, goodness, these are such great topics. So with baby lace, right, you mentioned you're able to use it to determine if there's a true, restricted tissue versus what tension maybe surrounding the area. Is that what you're finding? And you can release that tension.
I'm gonna share a screen. This is an adult, but just kind of for fun to show you a example of doing this laser procedure on an older patient. So can you see that?
Yeah.
So this is obviously an older patient, but you know that we want to get a patient from here to here to have a really nice release. This patient's not ready. This patient is. It takes a lot of body work and myofunctional therapy, and the surgery is so much nicer and easier on this one. But it only took us 5 minutes to get the patient from here to here.
Oh, wow. Okay.
Yes, that's the power of the laser procedure. I got to co-teach the first baby lace course with Angie Tenholder, and it just didn't, it was obvious that wasn't going to work out for me to go and teach with her often. So I asked Derek, I also teach osteopaths and chiropractors a lot more. And so I asked him if I could trademark it under a different name, because there was an issue with the original name and so forth. So that's why it has 2 different names.
Gotcha.
Because we teach it differently, but it is a psychosensory therapy, and it's also has a lot of direct effects. So the direct effects, if you look at some of the work on fascia, we know that normal fascia can change shapes, right? So if you're going to hit me in the arm and I know it's coming, I'm going to armor my fascia, and that's going to be one type of response, versus if I didn't know and I don't armor. So it's kind of like to give you a mental picture of how fascia can change shapes. And so with any age patient, I have like in the presentation, which maybe we'll bring up, maybe not, but basically there are a lot of different things that can make someone's frenum get short and tight. So secondary airway issue, because the genioglossus muscles are airway dilator muscles, they can in effect basically short and tighten and pull the tongue forward using part of the frenum. And so when you look at that patient, you'll think, oh, that's a tongue tie for sure, just look at it. But when you apply the laser, it liquefies the hyaluronic acid. So hyaluronic acid is our lubricant, and it should be loosey-goosey everywhere. And when you're like this from typing all day, you think your muscles hurt, but you really have fascial strain patterns and gummy fascia. So the laser at the specific wavelength, the 1064, liquefies the hyaluronic acid on contact. So what'll usually happen from that is you'll see that change, like of that tongue that I showed. I call it cobra tongue, but you'll see this change. And sometimes in children, we'll see the frenum double or triple in length.
Oh,
so
wow.
when you think you have a posterior tie, it's like, oh, well, it's pretty far back there, but wow, it's so short. A lot of those aren't as short as you think. Low tone, core instability, these are other things that can cause the person to use that deep fascia line to kind of keep it all together. So the laser gives us that little window to say, oh, okay, this isn't a structural problem. This is a functional problem. And then the psychosensory part of it is really powerful. And that I teach that, so I could go into a lot of that, but it helps to integrate primitive reflexes. It helps with pre-verbal trauma and just trauma in general in older patients through that limbic system and the window that it opens. And yeah, it does really powerful things. And even though we're staying in our scope of practice as a dentist, the brain is just right under these big muscles right here and things like
Yeah.
that. So I think some of it is also the transcranial laser aspect of it, which is pretty powerful. So did that answer the question?
Yeah, no, it's so fascinating. It's one of those things where, first of all, I just want to mention real quick, any slides that are shared, you can view on YouTube. We always post our episodes on YouTube, so we'll make sure that you guys have the link to that. But basically it was initially a picture of a tongue that looked a bit more heart-shaped actually when it was ready for release than it did initially in the initial photo. And it's so interesting because I know like sometimes we get kids with these like truly like heart-shaped tongues, and like, look, yes, there are real tongue ties. Nobody's questioning that, but it's one of the reasons that we always recommend, regardless of presentation, we recommend, our intervention as well before you just send a child or adults into a release. One, we have to prep, right? But two, there's usually always some degree, at least we find, of tension surrounding a tethered tissue because of compensations. Like there's just no way around that. The body has to compensate. It's naturally going to do that. You're going to then carry tension. Where you carry the tension may vary. The degree in which you carry it may vary, but especially in families who are hesitant and, younger children, if we can avoid these procedures, then by all means, like, let's see what we can do behaviorally or with, things like myo feeding, laser, like what we're talking about here, what can be done to see if we can bring the child back to function and out of dysfunction. And so I love that these kinds of conversations are happening, because I think that publicly it's usually tongue tie versus not tongue tied, and release it or don't release it. Everybody tries to make it so black and white. And we're like, when you actually work with these patients, there's so many more variables. And like you said, there are other things that can make the tongue appear to be restricted. It could even be a small palate where the tongue just doesn't fit. And it's just behaviorally learned to rest on the floor of the mouth, and they have challenging time lifting the tongue up. They've never had to before. So why would they start now? One of my therapists showed me a video of a patient she actually assessed yesterday. And she said, she was like, this 5-year-old, he couldn't elevate his tongue at all. And you see these children, raise their head and neck up and try to then take their fingers to lift their tongue up. And that doesn't need, he appears tongue tied right now, but he's new. We'll see what happens. It's one of those things where we don't know how far we're going to get. Usually in our sessions, within like 3 sessions or so, and that's like initial eval and 2 to 3 sessions afterwards, we typically are able to get, and obviously referrals, referring out, working with others, body work, everything is important component here. But we can usually determine, okay, this child needs to go for a release consult, or this child really doesn't. Let's continue to work together here. Because our goal is never to keep a child in therapy, and our goal is never to send a child for a release consult who may not need it, know? And so I love your team approach. I love the model. I love that you have all these providers, at the disposal of your patients. They're able to, they trust who they're working with. Everybody's kind of on the same page. You can have that interdisciplinary, case review and conversations. It's so powerful. And I always talk about, I remember this one case where it was my entire team and then some other providers as well, and multiple disciplines sitting around my kitchen table. And we literally passed a laptop around the table with the case. We'd all seen this patient, with the exception, I think, of one of the PT osteopaths. And the way that we presented the case and what we were concerned about was different from every single provider that saw this case. And as we all started to discuss it, it just became, and this was like years ago, but it just became so apparent how critical these conversations are. And really at how much of a disadvantage patients are at when they don't have the ability to have this team approach. So anyways, I'll shut up, but I just love your model.
No, I'm glad you mentioned that, because it's probably been maybe 7 years ago that I started an interdisciplinary study club. I think that's the first one like it, at least in our area. And so our first scope, so it's IBCLCs, SLPs, sometimes midwives, doulas, osteopaths, chiropractors, myofunctional therapists, pediatrician, functional pediatrician, now pediatric neurology. So I totally hear what you're saying, because what was so wonderful about that group is I remember going like, what's the difference between an osteopath and a chiropractor? I really don't know. And like,
Yes.
how do you, and so
And
that,
CST, and you need to know what these
yes.
different domains specialize. Like, what do you do?
And
Right
exactly.
on.
And so, and like another thing, I was just on a call last week, kind of doing a little teaching thing. And one of the people in the Q&A time was saying, oh yeah, well, do you think that laughter is great as a psychosensory therapy like EMDR, because EMDR doesn't cover certain things? And Karen D was on there with me. And so anyway, long story short, I'm telling him what I think about blah, blah, blah. And Karen D's, and I noticed he had a torsion, like, cause I just look at people and I'm like, oh, left side bend, kind of that sort of thing. And so I was like, it looks like you have a torsion. And then Karen D chimes in and she's like, yeah, so if your sphenoid is actually, lopsided, so to speak, from the torsion, then the EMDR therapy is not going to be as powerful for that person. And that's probably something that the EMDR person doesn't even really think about. So I absolutely feel like collaboration. I've learned so much. And my first experience was at the craniofacial team at Seattle Children's Hospital when I was an attending there and on that team. And that's when you'd sit there on Monday morning and recover a few cases, and you have the whole team there. So you see what your role really is for that patient. And sometimes your role is little to none, or like a way back seat, because there's all these other things going on. And also, like you said, if they're getting a tongue tie release and they have one of these other issues, those are those babies and kids that are healing tight, because the body will use that opportunity to scar it up and make that tension really secure. So yeah, team approach. There's just no other way to do it anymore.
Yeah. Yeah. I know, it reminded me of one of those conversations. We had a vision therapist who also had OT. It was a very interesting couple where they were both vision therapists. But the wife was also an OT. And so it just the brilliant practice, but hearing from them how like the impact on vision therapy and the, then the impact of vision therapy on myo. And I'm sitting here going like, well, yeah, because you're talking about vision and eyes and an occipital load and the sphenoid bone. And I'm just like,
oh my gosh.
Okay, hold on. And now it makes sense. And I'm like, and these, okay. And you start like putting all the pieces together, but it's just so fascinating. We always say like, we're connected from the tip of our tongue to the tip of our toes. Like everything is interconnected with fascia, but also we have bones.
I actually changed my vision in my late 40s. I started doing ALF and I got 11 millimeters more arch length in my late 40s by doing the ALF appliance. And I had 2 different prescriptions in my eyes because I'm missing a lateral on this side, and I finally made room and now I'm consolidating. But there were 2 different prescriptions, and in the process, when my palate went from super asymmetrical to more broad and even, now my vision's the same in both eyes, because the roof of the mouth is the floor of the eyes. I know, we just don't think about that stuff.
Yeah. I mean, I did the DNA Vivos, and I remember like my dental colleague and I, like we were sitting, she's like, you're developing cheekbones. Do you realize like you have cheekbones that like were hidden before? She's like, they've always been there, but you couldn't see them.
Yeah.
And it was so interesting to see like the changes, but also, symmetry and, to the extent that I can as an adult, it was very fascinating. And I look at my face like then versus now, and I had ortho, I had all, I also had relapse and all the things, but yeah. And just nasal surgery 3 months ago that I'm still healing from, but it's an ongoing process, and every step of the way, well, I tell everyone it's a journey. It's an investment in time, energy, money. Like it's totally worth it. Like I can breathe through my nose equally on both sides now. It's pretty cool.
Amazing.
Who knew that would be such a cool thing, right? Speaking of which, so going back to our like birth to 3, population, when do you, since I know you get them in there earlier on than maybe even some other dentists, when are you seeing those initial signs of airway issues or sleep issues and whatnot?
Let me go ahead, if it's okay, and I'll share again, and I'll show you, I put together some signs of airway issues in the 0 to 3-year-olds. So first, Hallie, I wanted to say that, well, let me screen share this here, but that it's not a very well-defined problem. So if you Google right now and ask, what are signs of sleep issues or airway issues in infants to toddlers, other than SIDS information, there's really not a lot out there. There's some new research out there, which is kind of concerning, but there's very little amount of information. And it's a growing problem. And I could talk a lot about why I think that's happening, but it's happening a lot more in infants and young children having sleep disordered breathing. And so the current situation is, if you have someone really young, it's a sleep study and a CPAP. If it's severe. If it's not severe enough for that, then it's like, let's watch it. But at a certain point, they're too young for adenoids or tonsils to come out. I'm a root cause girl anyway, so I don't lose very many tonsils or adenoids in my practice. But here are some signs and symptoms that we have collected in my study club. We just right now, so we did 0 to 6 month old for 6 years. I mean, literally 6 years. We talk about 0 to 6 month old pre-crawling infants. And now we've expanded to 0 to 3 years old. And next month, pediatric neurologist who treats sleep in the youngest of kids, who I collaborate with a lot, she's going to be speaking to us. So these are some things you might notice: open mouth posture at rest, a low tongue posture, audible breathing, retractions, snoring is never okay, the high, narrow, or misshapen palate. So here's some you might not know though. When you lay a little baby down, one of my friends, I didn't have time to see if I could borrow his video and show, but he's in Singapore, and he has this great little video where there's this one baby, and it's so cute, but it's kind of fussy and moving and making little noises, and you lay that baby down on its back, and it's very uncomfortable. You can see that, and it immediately turns to the side. And I see so many babies, like, once it's in my head of like, oh my gosh, this baby's struggling. Now I can't not see it, but I think of how many parents and just people in the world are just, oh, it's a fussy baby. He just likes to be held, or he's got this or that. But it's when you lay a tiny baby down and they're turning, that's a red flag. And sometimes you'll have parents saying, oh, my baby's so strong. He's got such a strong neck. No, it's not a strong neck. He's trying to breathe. And then the babies that aren't born with torticollis, although having torticollis makes them, set up for some other things. But when they develop torticollis in the first few months, again, it's that really strong preference, because turning the head to the side helps them to breathe. Arching, even though we think of arching a lot with digestion and reflux, but it also can be a sign of airway issues. A baby that thrusts their tongue forward. So also we see episodic masseter activation. That's basically those babies that are moving their jaws a lot. That's precursor to grinding, and grinding we know opens the airway. And so reflux, so that's Bernoulli's principle. If you have a restricted upper airway, that can create a negative pressure gradient, which causes reflux to happen. And then that creates other issues, but of course, dark circles. And then as you enter the toddlerhood, it makes me so sad sometimes for preschoolers and toddlers, because I feel like this whole terrible two, like, my daughter wasn't a terrible two. And I don't think terrible twos, or some people, oh, he didn't do terrible twos, he's doing terrible threes. I think some of this meltdown, low frustration tolerance, and just really challenging babies and toddlers, we might be missing an airway issue. That's my perspective. And so I'm really looking a lot closer at that now than I ever have before. And like I said, really just trying to collaborate and figure out ways to help these young ones sooner, because it's completely life-changing to be able to sleep versus not sleep in those really formative years. So so options, you can go to an ENT if they're too little. I have a patient right now that is 20 pounds, going to be 3 in October. Adenoids, 100% blockage, tonsils, kissing, has had multiple fall, head injury things, and she has severe sleep apnea, and she doesn't have all of her teeth in. So that's the big challenge when they're growing teeth. It's changing so rapidly. How can you get something to be retentive, but not lock up the cranium and things like that? So that's, but anyway, so neonatal ALF, I've had that for a while, 0 to 6 months, but now I haven't named the new appliance yet, but I'm working on it. And and then laughter. And that's another, using the laser non-surgically can sometimes get kids pretty far along, like pretty big changes. And then that may buy us time if they're not urgent to put in an early appliance. But yeah, so that's what else I have. So like some of the reasons I think it's happening more common, we know from like Kevin Boyd and others' work that mom who have hypoxia and sleep issues during birth, those kids are born more retrognathic. They are born just already predisposed to be mouth breathers and have hypoxia. Mouth breathing leads to enlarged tonsils and adenoids and inflammation of the airway and so forth. We also used to breastfeed until the 4th year of life, which is like crazy to think about it, right? But and in Mongolia, they still go to 7 or 8. But breastfeeding, a lot of people don't realize that it really is the first thing that we do that decompresses the cranium, because it's 23 bones floating in fascia meant to get really squished on the way out. And horses walk within a few minutes of birth, but humans take a year. So we're really neurologically immature, which gives us so much room for sophistication, but it also leaves room for a lot of error and challenges and gaps. So breastfeeding helps to do that decompression initially, and the way the jaws move, as you know, is much different on a bottle versus breastfeeding. And then solid foods. We used to give babies a little slab of beef jerky with no nitrates and sugar at 6 months and be like, work on that. So we don't do those things anymore. And I think those are the biggest factors related to changes, but I'm talking too much. So
no, this is great. This is great. And it excites me to hear these types of symptoms, because I feel like for my own children, and then from my private practice and experience in the courses that I've created, I've pulled these symptoms into my courses. And I've said, like, this is what we're seeing in infants. We're seeing, like you talked about, masseter, activation. I think that's probably the only thing that I haven't really highlighted. Everything else on your list is in my course. And like, I've, even educated on social media about these things, these babies with the strong, tight neck at birth. Those are both of my kids. And everyone's like, wow, your children have such strong necks. Look at them hold their head up literally at 2 days of life. And I was like, wow, I have a picture in the hospital on day 2 with my first daughter. She's on my chest, but her, her shoulders, her neck, her head completely just straight up, holding her own head up.
Wow.
My second daughter, I then knew that was not normal. And so we did start intervention much sooner. They were like, well, she doesn't have torticollis, but here's a paper with exercises to do at home that says torticollis. I was like, I don't care what you call it. Like, let's just figure out how to, help her develop properly early. Yeah. So, living it as a mom, I think also just gave me that passion to be like, what are these other symptoms that people are not like connecting the dots on? Like, you did such a beautiful job of kind of pulling in such a nice list of common symptoms that we see in these kids. And another one that I talk about too is like tripod sleeping. Like, my kids always, especially my first daughter, would flip herself onto her stomach, which was scary because she was like a couple months old and only wanted to be a belly sleeper ever. And she sometimes would have her little booty up in the air, with her head on her hands as an infant, as a young infant in the first 6 months of life. And it continued beyond that too. And I'm just glad that I lived in bliss 7 years ago and had no idea that was an airway issue, because now I don't think I would ever sleep. I'd be constantly trying to reposition her, figure out like, what the heck do we do so she doesn't put herself into a state where she may become a child with, who dies in their sleep. And it's just, it's like a sad truth that I now know. My second daughter was a back sleeper mostly, but we intervened much earlier on, like day 5 with the tongue tie release. I was kind of prepping her body. We were doing all kinds of things. We took her to CST and osteo, not until later on. I did just, PT. And, for her, it was like, okay, we're doing PT and it's like keeping her hitting her milestones, but like, we're not really closing any gaps. Like, she's still kind of on the far end. And I feel like I'm not convinced that this is like doing anything. I think it's just making me feel better. And so that's where I finally was like, okay, I need somebody else. And that's kind of what threw me into being like, all right, I need to understand what these osteopaths do and these chiros do with these babies and these, anyway, so I took her to both CST and osteopath, and it was like a whole world opened up for her with just a couple of sessions total. She went from not walking to standing up, like walking. And then she was also a kid who like dragged one of her knees behind her and did that little scoot on the knee across the room. And so instead of working, against the grain, we kind of went with it, and all of a sudden everything released and she was crawling on both knees after she knew how to walk. And, and that's where I was just like, okay, there is something more to this. Like, reflex integration, our nervous system, perhaps? Like, why is nobody talking about this?
Yes. I was trying to stop the share here, but I lost the ability to do that.
Oh,
Sorry.
No, you're fine. Let's see if it'll let me.
Yeah, I have a lot of pictures too, but again, I know it's a podcast, but I'll show you, for example, just randomly, but this is one of my favorites to show, because in this picture, we talk about the connection from head to toe, and this little girl, of course had crowding, wow. But her posture, her whole anterior chain has her forward. And this is about 8 months of just doing a little bit of, oh, hold on a second. Of doing a little bit of all the stuff that we're talking about. And it's just such a beautiful change. I think I had a picture of her teeth somewhere too, because, dentists, we make sure it's, yeah. So you can see like, I feel like that's our door in, right? My door in is the mouth, yes. But I get to make changes of the whole body. And that's super duper exciting. The reason I was showing this is just because this is a more, dated back skull, and look at the cranium and look at the jaw where it is, and this is just a few hundred years ago. I mean, that's just so sad how much change we've had.
It is incredible how we are moving out of, or not moving out of, but our jaws just continue to shrink. And I know there's that conversation that's happening about how, from one generation to the next, like, when does it stop? How do we stop it? How do we stop this progression and maybe even attempt to reverse it?
There's a whole Pottinger's cat book and all that, which I'm sure you've read. But there's so much more available too. I mean, I don't know how plugged in you are or your listeners to biohacking, but that's another really huge area where I'm definitely a biohacker. I've always been sort of early adopter and that sort of thing. But yeah, we're even working. So this is another kind of like tidbit, and I feel like I can just retire a happy woman if I'm able to accomplish this goal. But you know how so many kids, thanks for doing that, have persistent adenoid enlargement. So typically when I place the biomimetic tongue appliance, the adenoids and tonsils just drain and everything drains, and we don't lose them, they shrink. Mine shrank for the first time ever. I went from like, usually I'm a 3 or a 4, almost had them removed a few times, to a 1. And
that was my daughter with the ALF.
Yeah, it's so cool.
I have the CT that shows like the before and after of her sinuses, her adenoids, and people think I'm nuts. And I'm like, this happened in 3 months time, having that appliance in. We got it in end of August. Her adenoids shrunk and her tonsils during cold and flu season in Maryland in the cold weather.
Yes.
Tell me this was not the appliance, and we did absolutely nothing else.
It is the biomimetic tongue. So it's basically doing the job for the tongue until the tongue can. But there are cases, and I always get the hard ones because I do love the puzzle. And so those kiddos that have persistent enlargement of adenoids typically are mold toxic. So we're having Marcons or mold issues. And, but I'm working with a biohacker who's created a ton of different stuff to come up with not a spray, because most of the little kids hate them, and not surgery, but to shrink the tonsils and adenoids with potentially a supplement or a laser application. So that's really exciting too. I think that's going to be a huge game changer for a lot of kids, because nobody wants to put their kid under general anesthesia and cut body parts out, and adenoids regrow, and you've got to ask why they're that way and correct.
Right. And then there's that whole debate, like, well, adenoids are part of our immune system. Should we be reducing them or removing them? And it's, and I was like, I don't know where I stand on this topic yet, but I really, like, as a mother, I want to avoid procedures for my child that are invasive. She's a sensitive kid. Like, she's sensory, she's picky eater, she's like had all the things, like horrible breastfeeder. Like, she is literally the one who threw me down this entire specialty, pathway. And that whole rabbit hole was just like, oh, okay, well, here we go. So, and now I recognize that in everybody else in my family and my patients, and, but it was so fascinating too, because there was so much, even within the mild community, there was so much pushback that an appliance could possibly do that. And this was coming more from myofunctional. This was coming more from myofunctional therapists. Like, I was told to, so I put a picture up of her tonsils, and I was like, look, I was like, has anybody seen this happen? Because, my dentist was like, look, like, and she was going through the training. She was like, I'm told this can happen, but like my daughter was the youngest case she had treated yet at age 4. And she was newer to ALF. And she said, like, I don't want to make patients any promises. Like, yes, I'm being taught X, Y, and Z. She's like, I want to see this stuff happen, in my office. And then I can speak to what I'm seeing, what I've learned, and so on and so forth. And so, yeah, I posted it in a large group on Facebook, and I was messaged immediately by the moderator of the group and told to remove that post. I was absolutely out of my scope to suggest such a thing could even be possible. And this was like another speech pathologist and myotherapist. I was just like, I was like, you know what, this is my child. Like, I'm saying, this is what actually happened. Like, I know firsthand. I'm not claiming that this appliance does that for all patients. I'm asking if anybody else has seen it so we can have a conversation. And I was like, but you know what? Like, I'll just remove it. Like, it's not worth it. It's not worth it.
Share another one with you that is exactly the same thing.
And now I know they're seeing with expansion, they're also seeing a decrease in tonsil size. And, there's actually published research that's coming out on this, which is great to see.
Yeah, there is. This is, okay. So just keep this picture in mind, because I don't want to, I'm going to stop share for a second to go on the second one so you don't see the patient's name. But this is also an SLP's kiddo. So she took these pictures. And this is, I believe, 3 months later. So,
wow.
that it happens a lot. And the reason is, it's not really hard to understand, but if the tongue, so there's a picture I would love to share also with you. Let me go back to that one on my
it reminded me of Lily, because I have this like really great photo. I've shared it on social media of her tonsils. They're almost touching. They're inflamed. They look veiny. They don't look healthy to me. And she had a piece of like broccoli stuff in her teeth. So that was cute too. But I took her to the ENT with tonsils that looked like that, and was basically told that the ENT was like, I'm unimpressed by these tonsils. That was the ENT's word. Knowing that I'm an SLP, knowing what I do, working with other myotherapists. And she was maybe 3.5-ish, right? It was, before we went into the appliance at the time. And I'm like, look, I don't want surgery for her.
Right.
But I need her to breathe. Like, what are our options? Like, what can we do? And there, nothing, not a nasal spray, not no medication, no, let's monitor for 3 months, nothing, just turn me away. And this is supposed to be the specialist in this space. And I was like,
oh yeah, no, this is what I tell parents. This is a conversation to have at least once a day in my practice. And I just say, listen, if you go to the ENT with a young child and you're suspecting a sleep issue, I want you to know before you go, they have 4 choices and only 4 choices. Choice number 1 is they're going to look and say, I'm not that worried. Let's just keep an eye on it, which basically means you don't qualify for the other choices in their mind. Choice 2 is a spray, which is a steroid. What they're trying to do is shrink them to see if that helps sleep and airway get better. But nobody wants to keep their kid on steroid spray for any long period of time. And so if it works, or if it doesn't work and they move to option 3, which is cutting them out, what they don't tell you is generally 6 out of 10 times the kids will get better right away. 4 out of 10 times they don't. And then there's a huge almost 100% relapse at 2 years out for sleep, because the problem was not the size of those tissues, it was the size of the airway. And their 4th option is a CPAP, and that is all an ENT has to give you. And none of those options are root cause options. Let me show you another couple, just because I think you'll appreciate these, but I love this. Okay, so this is Kathy Holloway. She's actually a PT and craniosacral therapist. She helped, what's his name? Craniosacral therapist, Upledger. She helped Upledger get his stuff going. I love this drawing of hers, right? So she goes through embryology. And what you see here is the top is all neural tissue. The bottom is all gut. And the red is what's going to be your heart and cardiovascular system. And she just says, when she's teaching this, and this little silver nut right here is basically the primordial mouth. That's how early, 10 days old, that's starting to happen. And I love how she says the heart literally grows out of the mouth. And so we used to know, like, and focus so much on cardiovascular health. And then we learned neuroplasticity, and we focused a lot on that. And now we're understanding the gut. But little do we know that it's the peristalsis of the tongue from very early in the embryonic development that actually helps the embryo to fold in and unfold and develop. And another little known fact, but about 5 to 6 weeks, the roof of the mouth, what will be the roof of the mouth, a little bit of tissue invaginates, migrates upward, and there you have your pituitary gland. And the pituitary gland is a master gland. It's really, really important. And so not only is it so intimately connected, the nervous system, the gut, the heart itself and entrained, but also, function like the pituitary gland. And so this is without the pituitary is something that I always am teaching in my little infant clinic. And so I tell parents like, the bottom red line is your tongue. The top red line is the roof of your mouth. They should fit hand in glove. And when they don't, the yellow line represents the alterations that can happen. But the tongue exerts this strong force as compared to what it takes with braces. So 500 to 1200 grams of force on swallow. It only takes less than 2 grams to move a force with braces. What is all that force supposed to be doing when we're swallowing thousands of times a day? And one of the things it's doing is just draining all those sinuses. So there's a muscle that goes from your soft palate directly to your eustachian tube, and it's the back part of the swallow that sling muscle tugs and clears the eustachian tube. And then, so when you see little babies that are like Darth Vader babies, like they're not pumping, their tongue isn't pumping. And so, but the other thing directly above the nose and the palate is a perpendicular bone that goes right up to your sphenoid, and it pumps the pituitary and releases feel-good hormones and all these other things. And then not to mention all that force is also meant to help us drive our growth of our face and jaws forward and wider, because your airway is literally just the space in front of your spine behind your jaws. And so if your tongue is doing its job, you're going to get that great forward growth. But also I think I have one. Yeah, this is a really cool one. This is an amplified MRI. And so what I love about it, the left is non-amplified, the right is. Osteopaths have known for a long time that we have lymphatics, or that there is movement of the cranium. But so I love that video because you can imagine where the tongue, when it's resting low or low tone, you're going to have less movement of the entire cranium and nervous system. And when you got a really strong swallow that hits right back here, not only do you get all the drainage and all that other stuff we talked about, but you get really great motion of the cranium, which lends to great motion of, brain function and all that. But anyway,
yeah, no, I love that. That was a really cool video. And I experienced that firsthand as a patient with my expansion. I would hit a wall and I could not open the DNA appliance anymore. I couldn't turn it. It was just it wasn't that it hurt. It was my body's no longer responding. And I would go see the PT who is PRI trained and uses what he calls modern counter strain technique. And 45 minutes with him, and all of a sudden I can move my appliance again, because now everything is motion, all the motion is regained, everything's flowing properly. It's I think it's very similar to what I saw the osteopath do with my child.
Yes.
And it was just fascinating to me. I'm the body is literally locked up, and his whole thing is unlocking your body. And
Yes.
you have to be able, it's just all interconnected. So everyone's well, how does that work? What do they do? And I'm they can explain that better than I can. I just can tell you it works. I don't know what he did or how I did it. And, over the years I've come to understand it better, but I'm it works. That's all you need to know.
If I could go back to school again, which my husband says I can't, I would be an osteopath.
I love that. Well, I know we're wrapping up on time soon, but I want to talk. I know we talked a little bit earlier about non-surgical, intervention for potential ties or faux ties, as well as just, some of these cases where a tongue tie might reattach, especially infants and children who just heal really quickly. And, maybe they are getting proper care, maybe they're not, who knows? But what do you do when these patients, because I feel this is happening more and more, come into your office, they've already had a release, maybe they've had 2 or 3 releases, and they're not even a year old. Obviously there's going to be some scar tissue. What do you, and I know this is kind of a broad question, but
no, I love this.
How do you approach these patients?
So let's see. I'll just answer it verbally, but I have some pictures. But so first of all, I hate the term reattachment. I guess I'm the only person that hates that term, because in my mind, so there's 2 types of frenum. There's a normal one, which is just fascia, which can change shapes and properties. And there's embryonic fibers that have not undergone complete apoptosis, which those fibers don't stretch or change. And so we know both of those things from research. So when you release a tongue tie, assuming you did it properly, those fibers can't reattach. What happens next is the body decides what to replace it with, because we are all going to have a frenum. The frenum attaches the tongue to the mandible, and it's really important. So we're going to form a new one. And I personally believe that any person of any age that's had one surgery and they're looking like the way they did before, that's a huge red flag to stop, pull back, and problem solve. Because almost every single time they go in to get a second or third one, God forbid any more than that, you end up with not only scar tissue, but the potential for oral aversion and just, medical procedure trauma. So for us, we work really hard to green light first. That's not a fail safe, but it works really well in our practice. And then secondly, we like to see them about 1 week, and that's usually where my assistant's looking, because she's probably should be a doctor at this point, but so she's just looking for healing alterations. In the first days to weeks post-surgery, low-level laser therapy is a great tool to use. In fact, some of our families will buy a laser that we sell for $100 because it has 2.5-inch penetration, and it's a great wavelength for healing. You can also use it for like carpal tunnel and other stuff. But so we'll have them do every 48 hours low-level laser therapy. So that's in the days to weeks afterwards, because we know that low-level laser therapy encourages more idealized healing. I do not subscribe to the fact that poor healing equates to parents not doing a good job. Personally, I think if we look back hundreds and thousands of years ago, like hundreds of years ago and also up to thousands of years ago, it was a midwife with a sharp nail that just clipped the front tissue, and that allowed them to thrive. I maybe think that there's so much more going on and so many more changes than we really have wrapped our brains around, that we're focused on these frenums. But yeah, sometimes there's a lot more going on. And so low-level laser therapy is great in the initial time afterwards. My osteopath, at the time we didn't have those lasers, and I just loaned her one of our $7,000 lasers to take home, just because her child was at high risk, anterior tie, and she's an osteopath. She was working on him all the time, but she was like, wow, that was a total game changer. Her feeling his whole body and how that helped him. Once you get past weeks or months, that's when you use, I developed something, I didn't mention it, but I call it laser neural therapy, because neural therapy was developed in the 1920s by German surgeons who noticed that after a surgical procedure, sometimes the patient would have an upstream or downstream problem with another part of their body, where there was literally nothing wrong with that part of their body, but they were acting like there was, and it was from scar tissue. And sometimes their autonomic nervous system would also be off. So they would inject large needles into scars with prolocaine and into autonomic ganglia to get the result, which is very painful. I've had it. So that's what led me to go, wait, I have a laser that penetrates just as deep, blah, blah, blah. So I worked with my osteopath, and we call it laser neural therapy, but it's where we target at certain wavelengths to break up scar tissue. So that's always my go-to. I try to get the frenum without any scar tissue, very supple and bouncy. Then my eyes can see if the first release was complete, and, or if we're dealing with an incomplete release and a still tied, baby. On that note, I know you had Rachel Garrett recently, who she was my first associate for 6 years. She and I went to Dr. Giovanni Olivi, who is now a mentor of mine, and I co-teach a laser course with him. And we learned at that time in the US, everybody's taught to just use this horizontal, and they're often, CO2 or diodes, which are hot. Both of them are hot. I don't care what anyone says. But we learned actually that the proper technique is to start at the insertion and go down till just above the caruncles and vertically release. And using an erbium laser with water is a dissection. It's different than melting the layers together with carbon CO2 laser or diode. So we do that true dissection, and we go back vertically, and you don't need to go so wide. I'll show you one more picture. Just because I think it is, it's one of my favorite pictures. So this is an example of someone who was not prepared and who had a diode release, and you can see all the melting together. And this is someone who was prepared, who now this is even more aggressive. But why I like to show this when I'm teaching surgeons the procedure is this is normal fascia. Why do we need to open way up there? The frenum is simply right here. We don't even need to take the septum out. And in this case, we were a little aggressive. We took some of the epimysin layer. And in general surgery literature, if you take the epimysin layer at all and disturb it over those striated muscles, you always get scar tissue. So I think what we're seeing, Hallie, is that a lot of times people are not realizing that the way they're doing the surgery with this quick horizontal, look, mom, no blood, and melting all the tissue layers together, you're going to get scar tissue. You can't even see your field and your anatomy so well. So yeah,
we've seen that. I've definitely seen that. There's a dentist who's kind of notorious for going really wide. And one of the oral surgeons said to me, well, when you go that wide, you lose the ability to go deep enough sometimes, or you don't get the entire,
when you go
get the good relief.
As soon as you go horizontal, you lose your bearings, and
he's like, so it's a waste, basically.
Right.
The procedure is kind of like, what for?
And there's more contraction. Like when you're that wide, the skin has so much more, so you have so much more contraction.
And functionally, we see these kids come back and they can't move their tongue any better than pre-release. And we're going, like, we were racking our brains, like, what gives? Why is this happening? And that's why it came up at our study club. And, a provider said to me, well, this is why. Look at the type of release. And they were doing exactly what you explained, releasing, vertically, more so following that tethered tissue versus just going, straight horizontal line across. And so, we see the differences in children who are prepped the same way, who have, similar profiles. Obviously, there's always different variables, but the type of procedure, and I'm not an expert on lasers. We do have, I know, CO2 lasers in our area. We also have water lasers, and so but we've seen really good releases from providers who are doing it the way that you're explaining. And then, I know we don't have all day to talk about this, but it's this whole idea of reconstructing the underside of the tongue and like functional, frenuloplasties, especially in young children, just seems so abnormally invasive for many of these kids and adults too. I mean, my provider, I think, has, in the hundreds of patients that we've shared over years, I think ever did like 3 of them. And that was because there was so much skin under the tongue. It just, structurally, there were other things going on. It wasn't just because of the tongue tie or the frenum. So very interesting, like eye-opening experience. And I'm all about like, how do we upset the body and disrupt homeostasis like the least to get the child back to, function. And I'm also, a biohacker like you. So, I think I look at things very differently than many others may, even in this space. But I really appreciate, everything you've shared with us and your knowledge. You're brilliant. And so I'd love to hear more of your stuff, courses, whatever you have out there. How can people find you if they would like to?
Well, I'm the owner of Kidstown Dental. And so it's myself and Karen Long, who's amazing. Let me say that. She's got a great hand for surgery. And I teach a course twice a year with Dr. Giovanni Olivi. And so the next one's in October, and we're teaching laser pediatric dentistry with an emphasis on getting the patient ready, a team approach, how to properly do the surgery with any tool. So how to modify if you're using hot lasers to do it well. And I do cover a little bit of laughter, but I don't do the whole course in that setting. So that's really fun. And that's been a great way to meet a lot of people, but thanks for asking.
Yeah, of course. So we'll have kidstowndentist.com in the show notes and everything. They can find you there. And just thank you again so much for your time, your expertise, and this amazing conversation.
Yeah, this has been a pleasure. Thank you so much again, Hallie, for inviting me. I've had a lot of fun and I really enjoyed visiting with you today.
Thanks for listening to this podcast. If you want to hear more of these Myo, Tots, Airway, and feeding related episodes, be sure to leave a review on Apple Podcasts or pledge a small amount on patreon.com/the Untethered Podcast. If you found value, others in this space will too. So be sure to share this episode on your social media platforms and join us over on Facebook, on my Facebook page at Hallie Bulkin Biz, on Instagram at Hallie Bulkin, and you can head over to theuntetheredpodcast.com to grab a copy of the show notes, where you can also subscribe to be kept up to date on the latest podcast episodes.